السلام عليكم. وان شاء الله الحلقه بنشوفها تقريبا الناس اللي عندهم كسلاب فريكوينتلي، العيانين اللي بيجوا باكيوت مايكارديال انفاركشن وكاردياك شوك. واحنا عندنا the recent American College of Cardiology consensus opinion about the management starting from the definition نفسه اتغير، الميديكيشن recommended، الميكانيكال circulatory support how to use it، على الرغم ان الايفيدنس في الجايد لاينز not very supportive، لكن يمكن الكيس دي even not that sophisticated but some touch of the teaching points. Our patient is a 40 years old male smoker without other cardiovascular risk factors and not known to have any prior comorbid conditions. He came after 4 hours of severe classic persistent chest pain and his vital signs showed tachypnea, heart rate fast, blood pressure is 80/50 with hyperperfusion. He was cyanosed with cold clam skin, with AC3 gallop, and some systolic murmur, dilutic mitral regurgitation, with bilateral basal crackles up to halfway of the chest. This was that ECG. As you can appreciate, it is atrial fibrillation with segment depression in multiple leads, but AVR and all chest leads, there is clear segment elevation. You can appreciate also the right bundle branch block pattern, multiple criteria denoting severity of the myocardial infarction. The chest X-ray, the one to the left, it was the first one in the emergency, but the one to the right, it was the after he tackled by BCI, and this is the first X-ray in the ICU. You can see how wet is the lung, severe pulmonary edema in a patient with cardiac shock with acute myocardial infarction. His leukocytic count, of course, released later. We know that patient came MI, stabilized, TIC2, cath lab is strong recommendation, but WBC is high, is a marker of large infarction and poor prognostic marker. Creatinine was high, 1.8, CPK you can imagine, more than 11,000, and his saturation at room air was very low. The management, triaging from the ER, auto supply, aspirin loading, clopidogrel loading, 600, heparin, and because the patient is young, and we imagine there is high thrombus burden content, we give him tirofiban up front. Even this is not a routine recommendation. Patient started noradrenaline, and we know that the noradrenaline is the recommended vasopressor over dopamine and adrenaline in such cases. Respiratory failure, patient was intubated in the cath lab, and the blood pressure from the right arm showed 70/45 blood pressure, and even we started preemptive balloon pump support, intra-aortic balloon pump, improve the pressure partially to 86/50 millimeter mercury. Swan gans with catheter was inserted to assess and to maintain follow up the case. We know that the culprit is the left coronary system, and here is the RCA. Dominant vessel, and you can appreciate some diffuse disease, but the distal part is totally occluded. You can appreciate also to the left is the intra-aortic balloon pump against the vertebral column in the view to the right one here. This is the left coronary system. The left main bifurcates into LAD and LCX. The LAD is totally occluded from its proximal segment before giving any of its branches. And here is the LCX giving big obtuse marginal branch with subtotal occlusion. So RCA is total, LAD is total, LCX is subtotal. This can explain why he's like this. We inserted already the intra-aortic balloon pump from his femoral axis, and even with shock, we still work with radial, and even still the guidelines recommend radial over femoral axis, even in cardiac shock, if you can do it with good experience. We planned for protected thrombectomy to the LAD, and we show how is the protected thrombectomy. This is a bit an old case. With stenting to the LAD, the L6 is also good bonus. It is very clear at the reach, will not consume too much time to fix the LCX and plan to stage for BCI to the RCA. Again, before we see about total vessel revascularization, but the updated recommendation tackle the culprit only if you need. So the wire was but mostly BMW wire to the LAD. And you can see here something perhaps you never see before. There is balloon occlusion at the mid LAD With the first angiogram, we know that the plaque rupture is more proximal. This is PercuSurge balloon from Medtronic company. You inflate it by special device until it become oblong. It means it total occluding the artery. Once it become oblong, you stop. You don't inflate more. And you can appreciate that thrombectomy catheter is going down, from down the balloon all the way to suck any part of thromboid, embolize it down to the occlusal site of the balloon inflation. So this protected thrombectomy by device, occluding device. We know that there is filter non-occluding, but this is balloon occlusion. Remember this case, you might see it in some question, but you will never see in the current practice. It's not available anymore from Medtronic company. Here is the flow, it's the LED. You appreciate the plaque rupture site is the proximal LED before giving this sizable principal diagonal, and the LED mid segment looks to be somewhat narrow, diseased or spastic. Remember, you are in acute MI. Then we deploy the stent again with protection of the LED. We inflated the PercuSurge device again, and we deployed 3.5 by 18 millimeter stent at the plaque rupture site, at the culprit site. We agreed that time, shall we tackle the L6? Definitely yes, it is easy. You have the guide, you have the wire, it is simple, not totally occluded, easy task, very fast, good bonus, but we aim for only balloon angioplasty. We argue, shall we stent or not stent? Perhaps if I do this case, again now I will stent the L6. Anyway, we did BOBA, plain balloon inflation to the L6, and the result is good. At both, the L6 is clear. The LED, the culprit site tackles, but mid to distal part looks to be somewhat diffuse disease. We plan not to touch the RCA at this stage. Synchronized cardioversion for atrial fibrillation was important in this patient with cardiac shock. He need atrial kick. It was done in the cath lab. And patient still with high inotropic support, very poor circulation, and badly desaturating with high FiO2 ventilation. We inserted ECMO, extracorporeal membrane oxygenator. It is a catheter we insert from the femoral vein. It will be reached under fluoro up to the right atrium, taking the blood from the right atrium into external pump and oxygenator, returning back to the body through a catheter that stopped in the descending thoracic aorta, usually descending abdominal aorta. This is the extracorporeal membrane oxygenation, VA ECMO, venous to arterial ECMO. It helps for oxygenation, but it imposes some increased afterload on the LV. Patient started broad-spectrum antibiotic for sepsis. ECMO support was needed for 1 week, with IBB support for 2 weeks. Endotracheal intubation is extubated after 2 weeks. You can see how difficult is the case and how miserable is the patient. The patient, even after that, he was in good condition. We destabilized, started full, some early anti-failure therapy, and discharged home in a good condition. 3 months later, we brought the patient back. And here is the RCA. Bismillah. Okay. What we thought that it is CTO, actually it was not. It was a subtotal occlusion, severe diffuse disease at the distal RCA. The LED at 3 months is very good result. Even the area we tackle with BOBA to the L6 is fine. Still some collateral to the dominant RCA. And the LED without some mid to distal diffuse disease looks nice, very nice. It was some sort of spasm rather than true diffuse disease in the LED. Here is the RCA, as you can see, is bad distal disease, diffuse, but not totally occluded. You can find now better track to tackle the RCA. The RCA was tackled with stent from the distal RCA to the BLV branch, which is the bigger branch, and kissing balloon with the BDA, and this was the result at the RCA. Perhaps one just discussing this case, a patient with cardiac shock and 3-vessel disease with multiple plaque rupture, perhaps as we thought initially, with LED the main culprit and RCA. What to treat? Single vessel BCI, LED and stop. Multi-vessel BCI, LED, L6 and RCA. Just to keep supporting the patient, think about coronary artery bypass grafting. Distal protection in MI with cardiac shock, yes or no, to reduce the chance of distal embolization that can compromise the patient badly. and the role of early use of mechanical circulatory support, the intra-aortic balloon pump, and ECMO if you have, or Embella in some center in Egypt that have enough money to do. Thank you very much.